Okay, let's unpack this. We've got a powerful stack of material today, specifically excerpts from the European Society for Vascular Surgery's 2023 Clinical Practice Guidelines on Radiation Safety.
Hmm.
This isn't just a quick scan. Our mission is to take a deep dive, tailored specifically for you, the specialist clinician.
Right.
We're going to extract the most important nuggets, the key facts, the why behind the mechanisms, the crucial guidelines, even touch on areas where the evidence is still, evolving.
Yeah, the controversies too.
Think of this as your essential guide to truly mastering radiation safety in your endovascular procedures, drawn straight from this authoritative source.
And the authority is key here. These guidelines were put together by leading physicians and scientists, selected for their expertise by the European Society for Vascular Surgery.
So, top experts in the field.
Exactly. It's a rigorous synthesis of the best available evidence and expert consensus. You can trust the source material.
The context is undeniable. Endovascular procedures are booming. They're less invasive, fantastic for patients, but they fundamentally rely on ionizing radiation X-rays for guidance.
Absolutely essential for diagnosis and treatment in vascular disease. You need to see what you're doing.
And while that radiation is crucial for successful outcomes, we can't ignore the health risks. We're talking about potential cell damage, increased risk of cancer over time.
Affecting everyone in the room. The patient, you, the operator, the nurses, the technologist, everyone's exposed to some level.
Absolutely. While legislation provides a framework, these guidelines dive into the technical specifics needed for your practice.
Yeah, the how-to and the why.
Their aim is clear. Provide comprehensive recommendations for best practice in radiation safety, covering everything from measurement and biological effects to equipment, techniques, and training. It's really comprehensive.
It covers the whole spectrum. And they're built on the state-of-the-art scientific evidence, existing legislation, which is noted with a law level of evidence,
Meaning you have to follow it.
indicating recommendations that must be followed in relevant jurisdictions.
Yeah.
Like Class 1 or Class 3 recommendations often are. And fundamental physics principles, of course.
A really important point highlighted from stakeholder feedback is the need to communicate these risks to patients. Recommendation 1, that's a Class 1 recommendation based on level law.
So, mandatory again.
Explicitly states you must provide information on radiation risks in plain, easy-to-understand language before the procedure.
Not medical jargon. Plain language.
Patients need to understand what radiation is, why it's necessary for their procedure, and the balance of benefits and risks. It's vital for informed consent.
And ideally with written materials, too, so they can refer back to it. Patient understanding varies wildly, so clarity is key.
This brings us to the 3 core principles of radiation protection in medicine. First, justification.
The use of radiation must provide more benefit than harm for that individual patient. Is the exposure actually warranted?
Makes sense. Second, optimization.
This is where LRAC comes in. Doses must be kept as low as reasonably achievable LRA. This is the key concept for medical radiation protection, applying to everyone in the room.
Patient and staff.
Both.
Right.
How can we do this procedure effectively with the minimum necessary dose?
Third, dose limitation.
Right. Limits apply to individuals from planned exposure situations other than the patient's medical exposure.
Yeah.
So primarily, this is about occupational exposure limits for staff like yourself.
So for the patient, it's not about hitting a limit, but about
Justification and optimization.
Yeah.
The medical benefit dictates the dose needed for their specific procedure. You can't cap it if it means compromising the outcome.
Right. And remember, the understanding of radiation effects can evolve, so these guidelines are living documents.
Definitely. Science moves on.
What we're going to unpack today covers how we measure exposure, the biological effects and risks, monitoring occupational dose, practical dose reduction techniques, the essential equipment, education, and future perspectives. It's all drawn only from this document.
That's important. We're sticking to the source.
So what does this all mean for your daily reality in the endovascular suite? Let's dive in. #tag measuring radiation exposure and the associated risks.
Okay, let's jump into quantifying radiation. The guidelines emphasize that European law mandates improving radiation safety for both patients and staff.
It's a legal requirement.
Recognizing that occupational and patient exposure are linked and need an integrated approach. You can't really separate them effectively.
Yeah, makes sense. If patient dose is high, scatter to staff is likely high too.
Exactly. And complex procedures can involve doses equivalent to hundreds, even thousands, of chest x-rays. That really underscores the need for robust quality assurance and radiation protection programs in every center.
So how do we actually measure it during a procedure? The guidelines talk about indirect dose parameters measured by the C-arm itself.
Right. The first one is air kerma, or AK. It's measured in milligray, mg.
And what is air kerma in simple terms?
Think of it as the kinetic energy released from the x-rays into a small volume of air. It represents the radiation intensity at a point.
Okay, intensity. And there's this concept of the patient entrance reference point.
Yes, this is important. Imagine a point 15 centimeters away from the C-arm's isocenter, back towards the X-ray source, which is usually under the table in vascular suites.
Uh-huh.
The cumulative air kerma at this reference point, sometimes called cake in the U.S., gives you a good estimate of the radiation dose hitting the patient's skin surface right where the beam enters.
Got it. So AK is like the dose rate hitting the skin entry point. What's the other main parameter?
That's the air kerma area product, or KP. You might also see it as dose area product, DAP.
KP or DAP, same thing.
Essentially, yes. The International Commission on Radiological Protection prefers pKa for air kerma area product, but KP-DAP are commonly used. It's measured in gray centimeter squared. Kate doesn't.
How does that differ from air kerma?
If air kerma is the intensity at a point, KP-DAP is the total amount of radiation energy delivered over the entire area of the X-ray beam. It's the integral of air kerma over the beam area.
Okay, so AK is intensity, KP-DAP is total energy in the beam.
That's a good way to think about it. And the guidelines stress that KP-DAP and AK are preferred over just using fluoroscopy time, FT, for objectively measuring exposure.
Why is that? Fluoroscopy time seems intuitive how long your foot was on the pedal.
It is intuitive, and it does reflect procedure complexity and maybe operator efficiency to some extent. But it's a really poor dose indicator overall.
How so?
Because it doesn't account for anything else. Your C-arm settings, the tube current, the voltage, the field of view, any angulation, whether you're using low-dose fluoros or high-dose DSA, none of that is captured by fluoroscopy time alone.
Ah, I see. So you could have a short fluoro time but use really high settings or lots of DSA, and the dose could be huge.
Exactly. Studies show it correlates poorly with KAP or AK. So while you track FT, don't rely on it as your main dose metric. KDAP and AK are much more meaningful for dose audit.
Okay. KAP and AK for objective dose. What about comparing doses between centers or procedures?
That's where diagnostic reference levels, or DRLs, come in. Recommendation 4, Class 1, Level C recommendation says you should review patient dose values, like KAP or AK, at your center, and compare them to national DRLs.
And what are DRLs?
They're typically set at the 75th percent of the third quartile of the median dose values for a specific procedure collected from many different facilities.
So a benchmark based on real-world data.
Precisely. They're not dose limits, but tools to help you identify if your doses for routine procedures are unusually high or maybe even unusually low compared to the norm. It helps flag areas for investigation and optimization.
Makes sense. Okay, so we've measured the dose. Now the biological effects. This is the why we care part.
Absolutely. Ionizing radiation can cause harmful effects.
Yeah.
We categorize these into two main types. First, stochastic effects.
Stochastic, meaning random.
Essentially, yes. These occur by chance. The key things are the probability of the effect happening increases with dose, but the severity of the effect, if it happens, does not depend on the dose.
Probability goes up, severity stays the same.
Correct. And crucially, for radiation protection purposes, it's assumed there is NO, known threshold dose, below which the risk is zero.
No safe dose for stochastic effects.
That's the assumption we work with. The primary example everyone thinks of is the development of malignancy or cancer.
Okay. And how do we model this risk?
The internationally adopted model for practical radiation protection is the linear no-threshold LNT model. It basically draws a straight line, posits that risk is directly proportional to dose, right down to zero dose.
So even the lowest exposures could theoretically carry some risk.
That's the premise of the LNT model. It's the scientific consensus used for setting protection standards, although, alternative models do exist and are debated in scientific circles. But LNT is the practical basis.
And how do we estimate this stochastic risk?
We use a calculated quantity called effective dose, E, measured in sieverts.
Okay.
Effective dose is complex. It represents the equivalent uniform whole body dose that would give the same overall risk of stochastic effects as the actual non-uniform dose received by various organs and tissues.
So it weights different organs.
Exactly. It considers the dose absorbed by each organ and multiplies it by a weighting factor based on that organ's radiosensitivity. The most sensitive organs listed are bone marrow, colon, lung, stomach, and breast.
So effective dose gives a single number for overall cancer risk.
Sort of. It represents the same stochastic risk as if the whole body got that dose uniformly. But calculating it requires complex modeling or software. It's not something you get directly from the C-arm.
So not for routine audits in the same way as KAP or AK.
Generally not recommended for routine audit, no. It's more useful for theoretical risk comparisons, maybe comparing different procedures or estimating risk for specific situations like exposure during pregnancy.
And other factors influence this risk.
Yes, age and sex are important. Because stochastic effects like cancer take time to develop, elderly patients have less excess lifetime malignancy risk from a given exposure compared to younger patients.
Makes sense. Less lifetime left for a cancer to develop.
Right. The guidelines give a striking example based on a reference. The estimated lifetime attributable risk, LAR, for cancer after a standard coronary CT scan. For an 80-year-old woman, it's about 0.075%, or 1 in 1,338 scans.
Okay.
But for a 20-year-old woman, it jumps to 0.7%, nearly 10 times higher, or 1 in 143 examinations.
Wow, that's a significant difference based on age.
It really highlights the issue, especially with multiple scans accumulating over time, particularly in younger patient populations who might need repeated endovascular procedures or surveillance scans. And partial body exposure makes interpreting effective dose tricky too.
Okay, that's stochastic effects, probability-based, no threshold like cancer, estimated by effective dose. What's the other type?
The second type is deterministic effects, which are also called tissue reactions.
Deterministic, meaning they will happen.
They will happen if the dose is high enough. These effects do have a threshold dose.
Wait.
Below the threshold, the effect doesn't occur. Above the threshold, the effect always occurs, and its severity increases with the dose.
So threshold exists and severity scales with dose above it. What causes them?
They result from radiation-induced cell death or damage on a large enough scale to impair tissue or organ function.
Examples.
Classic examples relevant to endovascular work are skin lesions, like erythema, desquamation, or even necrosis and lens opacities, which means cataracts.
So cataracts fall under deterministic effects. Or is it changing? We'll come back to that.
Well, traditionally, yes. But the threshold understanding is evolving, especially for cataracts. We'll definitely circle back. For skin, though, it's clearly deterministic.
How do we estimate the risk for these skin effects?
We look at skin dose parameters. There's entrance skin dose, ESD, which is the dose right at the skin surface where the beam enters, including backscatter. But more specifically, we use peak skin dose, PSD. This is the highest dose delivered to any single area of the skin during the entire procedure.
Why is peak skin dose the key one?
Because deterministic skin injuries depend on the dose to a specific area reaching that threshold. PSD is the best predictor. If the PSD exceeds certain thresholds, you can anticipate specific reactions.
What are some thresholds?
Transient erythema, like a sunburn, typically starts around 2 to 5 gray. Higher doses lead to more severe effects like permanent hair loss, skin breakdown, desquamation, ulceration, or necrosis.
And when are these high skin doses likely to happen?
The risk is definitely higher in complex procedures with long fluoroscopy times and, importantly, multiple DSA acquisitions, especially if the C-arm stays in one position for a long time, concentrating the dose.
Do we see these thresholds exceeded often?
The guidelines mention that exceeding the 2J threshold for transient erythema can occur in up to 30% of EVR procedures, according to one reference.
30%? That seems high.
It does. But actual clinically significant skin injuries are less frequent than that might suggest. This is likely due to dose fractionation, moving the beam around, and the skin's ability to repair damage between exposures.
Okay. Are there specific dose levels that trigger mandatory actions?
Yes. High-dose procedures causing skin injuries are sometimes considered unintended medical exposures, requiring specific actions like recording, analysis, reporting, informing the patient, and follow-up. The guidelines list example thresholds that might trigger this. Peak skin dose greater than 3 Gui.
3 gray, okay.
Air kerma at the patient entrance, reference point greater than 5 Gui, or kerma area product greater than 500 Gui, .cm melasa. These are indicators that a significant skin dose might have occurred.
Good to know those numbers. What about the basic biology? How does radiation actually cause damage?
At the cellular level, ionizing radiation can directly damage critical molecules like DNA.
Yeah.
Or it can act indirectly by creating reactive oxygen and nitrogen species free radicals, which then damage DNA and other cellular components.
Direct hit or chemical damage.
Right. This triggers complex cellular responses, including DNA repair mechanisms. We can actually detect this. Biomarkers like phosphorylated histone protein H2AX, gamma H2AX, or PATM pop up in lymphocytes after endovascular surgery.
Showing that DNA damage and repair has been activated?
Exactly. Levels usually return to normal within 24 hours, reflecting the repair process, but there's individual variation in sensitivity. And intriguingly, one study reference showed that using leg shielding actually mitigated this increase in DNA damage markers.
Interesting link between shielding and cellular response. Now let's focus specifically on the risks for patients and then operators.
Okay, for patients, the exposure isn't just during the procedure itself. You also have to consider post-operative surveillance, often involving CT scans, which adds to their cumulative dose.
Right, the total burden over time. Is there evidence of increased cancer risk after these procedures?
Some studies have suggested a weak signal or maybe a higher incidence of malignancy after endovascular repairs like EVAR compared to open surgery.
Yeah.
However, the guidelines caution that these studies have confounders and weren't really designed to answer that specific question definitively.
So, suggestive but not conclusive.
Correct. But we do know the cumulative exposures can be substantial. For TVAR patients, cumulative effective doses over 2 years can exceed 100 millitutrient.
100 millisieverts? That sounds like a lot.
It is. Based on LNT modeling, that level of exposure is estimated to potentially account for up to a 2.7% increase in the lifetime risk of developing leukemia or solid tumors.
So, a measurable theoretical risk increase and skin injuries.
Yes, as we discussed, skin injuries are a real deterministic risk from high exposures during complex procedures linked to exceeding those peak skin dose thresholds.
Okay, now for operators. You're facing regular low-dose exposure over potentially decades of your career. What are the risks?
Well, regarding malignancy, similar to the patient data, there's currently a lack of conclusive evidence directly attributing a higher incidence of cancer specifically to occupational exposure in interventionists.
Why is that?
Mainly due to limitations in past studies, inadequate dose histories for individuals, study designs not robust enough. The guidelines emphasize the need for better designed longitudinal studies that accurately track career doses.
So, the jury's still out on operator cancer risk, needs more research. But what about cataracts?
Yes. Radiation-induced cataracts, RIC. This is where the understanding has undergone a major shift, and it's incredibly important for anyone working in the endovascular suite.
What's the shift?
Historically, RIC was considered a classic deterministic effect, requiring a relatively high threshold dose, maybe 5 gray from a single exposure, or 8 gray from protracted exposure over time.
Okay, high threshold.
But another. The thinking, based on more recent epidemiological studies, especially in interventionists, is that lens opacities can occur at exposures significantly lower than 2 gray, and potentially there might be no safe dose threshold at all.
No threshold for cataracts. Similar to stochastic effects.
The evidence is pointing that way, or at least towards a much, much lower threshold than previously thought. Increased risk has been reported even at cumulative eye lens doses below 0.5 gray.
Half a gray, that's considerably lower.
It's a huge change in perspective, and it fits with findings that cardiac interventionists show a 3- to 6-fold higher risk of posterior subcapsular cataracts compared to the general population or unexposed controls.
Wow. Okay, that really underscores the importance of eye protection, which we'll get to. That's a critical clinical pearl right there, the evolving understanding of cataract risk at low doses.
So we've talked about dose units and the risks. Let's take a moment to just quickly recap the key measurement concepts.
Good idea. We've got air kerma, AK, which is like the intensity hitting the patient's skin.
Measured in milligray, usually at that patient entrance reference point.
And then air kerma area product, KAP or DAP, measured in gray centimeters squared. That's the total energy in the beam.
Right. And these two, AK and KAP, are much better than fluoroscopy time for actually tracking radiation dose objectively.
Because FT doesn't account for settings or mode, and we should compare our CAPAC values against National Diagnostic Reference Levels, DRLs.
Exactly. Use DRLs as a benchmark for optimization. Then the risks fall into 2 camps.
Stochastic think cancer. Probability increases with dose, no known threshold. We estimate this risk with effective dose, in sieverts, considering organ sensitivity and factors like age.
And deterministic or tissue reactions, think skin injuries, and historically, cataracts. These do have a threshold dose, and severity increases above it. We track this risk using peak skin dose, in gray.
But the big takeaway is the evolving science on cataracts, suggesting the threshold might be very low or even non-existent, making eye dose a major concern even at typical occupational levels.
Precisely. Understanding these parameters and risks is foundational for everything else we'll discuss. Hashtag measuring, monitoring, and reporting occupational radiation exposure.
Okay, let's focus now specifically on measuring and monitoring your occupational exposure as an operator.
Right. Unlike patients who get relatively high doses infrequently, you're getting regular low-dose exposures over your entire working life. So tracking the cumulative dose becomes really important.
And how do we do that?
Through personal dosimeters, the badges you wear. These measure quantities related to the dose your body receives.
What specific values do they measure?
The key ones are the personal dose equivalent. It's measured in soft tissue at different depths below the body surface. There's HP 0.07.
0.07 millimeters. That's very shallow.
Yes, that's related to the dose to the skin. Then there's HP 10, which is at 10 millimeters depth, and that relates to the dose to deeper organs.
Okay, skin dose and deep dose.
And there's also HP 3 at 3 millimeters, which is specifically used for estimating the dose to the lens of the eye.
Ah, important given what we just discussed about cataracts. Where should these dosimeters be worn?
Standard practice is usually one on the trunk, under any lead apron, to estimate effective dose. But Recommendation 9, which is Class 2B, Level C, suggests that endovascular operators may consider wearing additional dosimeters.
Additional ones where?
Specifically, at eye level, perhaps clipped to your collar or cap, outside the lead glasses, and also potentially on the finger or hand.
Why the extra locations?
Because your head eyes and your hands often receive significantly higher doses than your trunk, especially the side closest to the radiation source. This is due to your position relative to the patient and the direction of scattered radiation. An extra dosimeter gives a much better picture of the dose to these critical areas.
Makes sense. Are there issues with finger dosimeters, like sterility?
Yeah, that's a practical consideration. Awareness of sterility is needed if you're using ring dosimeters, for instance.
What types of personal monitoring devices are there?
Broadly, two types. First are the passive thermoluminescent dosimeters, or TLDs. These are the standard regulatory badges most people are familiar with.
The ones you send off each month?
Exactly. They absorb energy, and when heated in the lab, they release light proportional to the dose received. They provide an accurate record of cumulative dose over the wear period.
That's the drawback.
They cannot provide any real-time dose information during a procedure. You only find out your dose weeks later.
So you can't adjust your behavior based on the reading in the moment?
Correct. That's where the second type comes in. Active personal dosimeters, or APDs.
Active, meaning?
Meaning they provide an immediate electronic reading of the dose rate and the accumulated dose, usually on a small display visible to you while you're working.
Ah, instant feedback.
Precisely. This real-time feedback is incredibly valuable. If you see your dose rate suddenly spike when you lean in or use a certain angulation, you can immediately correct your position or technique.
So APDs can actually help you reduce your cumulative dose by modifying behavior on the fly.
That's the potential benefit, yes. By making the invisible visible, they enable learning and adaptation during the procedure itself.
Compliance with monitoring is obviously key.
Absolutely mandatory. Recommendation 5 is Class 1, Level Law. All personnel potentially exposed MST comply with European and national legislation regarding dosimetry and dose limits.
And this involves categorizing workers.
Yes. Staff are typically categorized into Category A or Category B based on their potential exposure risk. Category A workers are those likely to receive higher doses, potentially more than 6 mSv effective dose per year, or more than 15 mV to the lens, or 150 mSv to skin extremities. Category B are below these levels.
And who decides the category?
This requires the advice of a qualified expert, usually a medical physics expert, MPE, or a radiation protection expert who assesses the workplace and typical exposures.
But the guidelines also say interventionists can mitigate risk.
Yes. By consistently following established safety practices and using the techniques and equipment we're about to discuss. Your category reflects potential risk, but your actual dose depends heavily on your practices. Hashtag dose reduction techniques.
Okay, let's get into the practical stuff. Dose reduction techniques. This all comes back to that core principle.
ALA-ARA. As low as reasonably achievable. Doses to operators and patients must be minimized, consistent with achieving the diagnostic or therapeutic goal.
It's not about zero dose, but the lowest necessary dose.
Exactly. And radiation safety really starts with developing good habits and understanding the fundamental physics principles. It's always a balance of benefit versus risk, and LR is the framework for managing that balance.
How do different imaging modes impact this?
They have vastly different dose implications. Basic fluoroscopy is your live X-ray view, used when you need to see movement, guiding wires, catheters, deploying devices.
Lower dose, generally.
Generally, a lowest dose rate, yes. Then you have digital subtraction angiography, DSA. This involves acquiring a sequence of images, subtracting a mask image taken before contrast injection to get a clear view of the contrast-filled vessel.
Like a quality image, but
Much higher radiation dose per image compared to fluoro, as we'll discuss more. And then there's cone beam computed tomography, CBCT.
that's that.
This involves the C-arm rotating around the patient to acquire data that can be reconstructed into cross-sectional 3D images right there on the angiography table. It's processed on a workstation for multiplanar and 3D views.
Like having a CT scanner in the angio suite, dose implications.
Dose varies considerably depending on the system, the protocol used, and the area scanned, but it can contribute significantly to the total procedure dose. Useful, but needs justification.
Okay, let's talk specific techniques for keeping dose low, starting with the basics.
One of the most fundamentally important factors is simply pedal time. How long your foot is actually activating the X-ray beam.
Minimize foot-on pedal time.
Absolutely. Use fluoroscopy only when you need dynamic information. For static checks like confirming wire position after movement or checking balloon inflation-deflation, use short taps of spot fluoroscopy. Get the image, get off the pedal immediately.
Don't just keep your foot down continuously.
Please don't. Also, consider fluoroscopic loop recordings. Many systems allow you to record a short fluoro sequence. You can then replay this loop to review a dynamic process, sometimes avoiding the need for a higher dose DSA run just to see something again.
Good tip. What about last image hold?
Another crucial feature, available on basically all modern units. When you release the pedal, it displays a frozen image, often an average of the last few frames.
So you can look at the image without ongoing radiation.
Exactly. You can take your time to study the anatomy, measure things, plan the next step, all without irradiating anyone. The guidelines note it's actually a mandatory feature required by the US FDA.
Important to use it routinely. Now let's revisit DSA and frame rate because you flagged this as a major dose contributor.
It really is. DSA gives you those beautiful high-contrast roadmaps, but it comes at a steep price in terms of radiation dose. The guidelines emphasize that this is often underappreciated.
How much higher is the dose compared to fluoroscopy?
Studies referenced show DSA can account for 70–90% of the total procedure dose in peripheral or cardiac interventions, and 50–80% in AVAR-TAVAR, even when using relatively low frame rates.
Wow, the vast majority of the dose often comes from DSA. Why is it so much higher?
Two main reasons. First, DSA frame rate, the number of images acquired per second, is different from fluoroscopy pulse rate, the number of X-ray bursts per second.
Yeah.
Second, and more importantly, the dose per individual frame in DSA is typically at least 10 times higher than the dose per pulse in fluoroscopy.
10 times higher per image.
At least. Think about typical doses. One fluoro image might be 10–30 milligray at the entrance point. A fluoro loop recording might be 100–300 milligray. But a single DSA acquisition run, that can easily be 1,000 to 3,000 milligray or even more.
Huge difference. And the impact on operator dose.
Significant. One study found operators receive about 8 times higher scattered dose during DSA compared to during fluoroscopy.
Okay, this is a critical take-home message. Minimize DSA use.
Absolutely. Recommendation 14 is Class 1, Level B, based on physics principles. Use the lowest frame rate necessary for the clinical task when you do need DSA.
Don't just default to high frame rates.
No, ask yourself, do I really need 3 frames per second, or would 1 frame per second suffice, or even less for some situations? Limit DSA runs to only the key scenes or critical steps where you genuinely need that high-quality subtracted image.
And consider alternatives.
Yes, could a fluoroscopy loop recording substitute for the DSA if absolute peak image quality isn't essential? Determine the lowest acceptable image quality that maintains procedural safety. Modern C-arms have features that help, like overlaying previous DSA runs as roadmaps, or using fluoroscopy road mapping.
So be extremely mindful of every DSA run. Next technique, collimation.
Collimation is your friend. It means using the adjustable metallic shutters or apertures within the X-ray source housing to shape the beam and restrict it to the smallest necessary field of view, just the area you need to see.
Like putting blinders on the beam, what are the benefits?
2 main benefits. First, it directly reduces the volume of patient tissue being irradiated, which lowers the patient's overall dose, specifically the CAPI-DP. Second, by reducing the irradiated volume, it reduces the amount of scatter radiation produced.
And scatter is the main source of dose for staff.
Exactly. The reduction in scatter is generally proportional to the reduction in the beam area. The guidelines mention a figure showing KP reduced from 42 to 14 milli-GI.cms for Senu 1. Just by collimating, that's a huge saving. Collimation also tends to harden the beam slightly, which can improve image sharpness.
What kind of dose reductions are we talking about?
Examples cited include 40% reduction in scatter dose in cardiac procedures and potentially more than a tenfold reduction in KAP with really meticulous collimation. Specific horizontal or vertical collimation can slash scatter dose to staff by 80–96% in some scenarios.
Impressive. Is there any downside to collimation?
One caveat. If you collimate very tightly, you are concentrating the primary beam onto a smaller area of the patient's skin. While overall dose, KAP, goes down, the entrance skin dose in that small area goes up.
Increasing the peak skin dose locally?
Potentially, yes.
Yeah.
So if you're using tight collimation, avoid keeping the C-arm parked in the exact same position for a very long time to prevent building up a very high PSD in one spot. Modern systems often have virtual collimators displayed on the screen to help you position them accurately without extra fluoro.
Good point. What about the anti-scatter grid?
Recommendation 16 is Class 2A, Level C. Consider removing the anti-scatter grid when scatter radiation is expected to be minimal, like in pediatric cases or very thin body parts. The grid improves image quality by absorbing scatter before it hits the detector, but it also requires a higher initial dose. Removing it can lower dose when it's not needed.
Okay. What about advances in the equipment itself, dose reduction hardware and software?
Yes, vendors are constantly working on this. It's a major focus. Reducing dose while maintaining or even improving image quality.
How do they do that?
Several ways. One, machine controls. Things like using smaller focal spots, shorter X-ray pulses, lower tube currents, adding extra filters to the beam to remove low-energy radiation that doesn't contribute to the image but adds to skin dose.
Okay. Optimizing the beam itself.
2, image processing algorithms. Sophisticated software that cleans up the image after it's acquired. This includes things like automatic pixel shifting to compensate for motion, temporal averaging, spatial noise reduction algorithms, image enhancement techniques.
Making a lower dose image look better.
Essentially, yes. 3, hardware configurations. Optimizing the entire imaging chain from source to detector for better efficiency.
And does this actually work in practice?
Yes. Studies cited report significant dose reductions when centers upgrade to newer systems with these technologies. Examples include dose being halved in EVA, 70% reduction in lower extremity peripheral artery disease procedures, 40% in embolizations. The tech definitely helps.
Planning ahead also seems important. Preoperative planning software.
Hugely important for both procedural efficiency and radiation safety. Recommendation 17 is Class 1, Level C. Detailed preoperative planning is recommended.
How does it help reduce radiation?
By thoroughly analyzing the patient's anatomy on 3D workstations, using their pre-op CT scan, you can plan the entire procedure beforehand, choose landing zones, anticipate difficult anatomy, select appropriate devices. This limits the need for unnecessary diagnostic runs during the procedure just to figure things out.
So less shooting needed because you already know the plan.
Exactly. You can also identify the optimal C-arm angles needed to view specific targets and save these angles as presets, reducing the time spent hunting for the right view with live fluoro.
Very efficient. What about 3D image fusion software, 3DIF?
This takes planning a step further. 3DIF, or image fusion, involves overlaying the 3D anatomical model from the preoperative CT directly onto the live fluoroscopy image during the case.
Like a GPS roadmap on your fluoro screen?
That's a great analogy. It creates a virtual roadmap. Recommendation 18 is Class 2A, Level B. Image fusion should be considered for aortic endovascular procedures, where it's particularly useful for navigating complex anatomy, like in EVAR or FEVAR-BVAR.
Does it demonstrably reduce dose?
While there aren't many randomized controlled trials looking only at fusion's impact on dose, comparative analyses and meta-analyses do show a trend towards lower cap-DAP with fusion, and some studies identify fusion as an independent predictor of dose reduction.
So, promising evidence, especially for complex aortic cases.
Yes, and more sophisticated systems are emerging, using cloud-based AI for real-time adjustments and more accurate overlay, which studies suggest can reduce radiation, fluoro time, and overall procedure time. There's also emerging evidence for its benefit in lower extremity procedures.
Let's talk about the detectors. Image intensifiers 2 versus flat panel detectors, FPDs.
This is largely a historical point now, as most new systems use digital flat panel detectors. FPDs replace the older analog image intensifiers.
And FPDs are better.
Generally, yes. FPDs offer superior performance, higher sensitivity, better signal-to-noise ratio, wider dynamic range, less geometric distortion, better image uniformity, more potential for advanced image processing, and often better maneuverability.
Do they inherently mean lower dose?
They have the potential for lower dose due to their higher efficiency, but optimal use is key. The guidelines suggest using the lowest pulse rate or lowest fluoroscopy dose mode possible, especially for simpler procedures where high image quality isn't paramount. Doing so can reduce dose by around 15% compared to standard modes on FPD.
So FPDs are better, but you still need to use low-dose settings. Now, magnification, how does that affect dose?
This is another really important concept to grasp. Conventional magnification on most C-arms works by electronically selecting a smaller area of the detector to display over the full monitor screen.
So you zoom in by using less of the detector.
Exactly. This increases spatial resolution, letting you see finer details, but there's a significant dose penalty. Because when you select a smaller detector area, a smaller field of view, or FOV, the system's automatic brightness control, ABC, or automatic exposure control, AEC, automatically increases the radiation output tube current, or pulse width, to maintain the same brightness level on the monitor.
Ah, so smaller area needs more juice to look as bright.
Precisely. The dose increase is roughly inversely proportional to the square of the change in FOV diameter. So if you have the FOV diameter, you roughly quadruple the radiation dose rate to that small area.
Quadrupled the dose? That's huge.
It is. So the rule of thumb is smaller FOV equals higher patient dose rate. The system usually automatically collimates the beam to the selected FOV to avoid irradiating tissue outside the displayed area, which is good for reducing scatter to staff, but it means the entrance skin dose in that magnified area is significantly higher.
So the advice is?
Use the largest FOV possible that allows you to see what you need to see. Use conventional magnification judiciously, only when absolutely necessary for visualizing critical details.
Is there an alternative?
Yes. Digital zoom. This is a feature on many modern systems. It works differently. The image is acquired using a larger FOV at a lower dose rate, and then the system digitally enlarges a selected region of interest after the image is captured.
Like zooming in on a photo on your phone.
Exactly. It's post-processing magnification. It does not require increasing the radiation dose. Some systems offer live zoom, which does this in real time.
And the dose savings
Can be substantial. Studies estimate up to a 2.5-fold dose saving compared to conventional magnification, or around a 30% reduction compared to just switching to the next smaller FOV. One study in coronary procedures found non-inferior visibility with digital zoom compared to conventional mag, but with about a 30% saving in air kerma and KK.
So the recommendation is clear.
Yes. Recommendation 20 is Class 1, Level C. Digital zoom and appropriately sized high-resolution monitors are recommended over conventional FOV-based magnification whenever possible.
Great tip. Modern machines also provide dose reports, right?
Yes. Modern systems provide very detailed dose reports, often showing cumulative and mode-specific dose information for fluoroscopy, DSA, CBCT, etc. This data is incredibly useful for tracking, auditing, and optimizing your practice.
And it's required.
Recommendation 21 is Class 1 level law. Real-time dose information must be provided by the C-arm system to help optimize radiation protection during the procedure. And all this dose monitoring data should be recorded institutionally, often automatically, via DICOM dose reports.
What about maintenance?
Also mandatory. Recommendation 22 is Class 1 level law. Regular maintenance and assessment of ionizing radiation equipment must be performed. This ensures the equipment is functioning correctly, doses are accurate, and safety features are working.
Who's responsible?
It involves the institution having quality assurance programs, the medical physicist performing checks and calibrations, and the vendor providing service according to contracts. Regular audits of policies are also needed.
Okay, let's shift to the room itself. Endovascular operating rooms. Mobile C-arms versus fixed systems.
This is a common practical question. Mobile C-arms, while flexible and cheaper, generally have inferior imaging capabilities compared to fixed systems. They're more prone to overheating during long cases.
And the radiation safety aspect.
This is key. Mobile C-arms typically result in increased operator exposure.
Why is that?
Primarily because they usually lack the integrated table-mounted lead skirts and ceiling-mounted protective shields that are common with fixed systems. Ergonomics can also be worse, potentially forcing operators into less ideal positions relative to the beam.
Interesting. But do they produce less radiation overall?
Some studies cited suggest that mobile C-arms might actually generate LSS, total radiation dose, e.g. lower KAP, during procedures like standard EVAR compared to hybrid suites.
So less patient dose, but more operator dose. How does that balance out?
It's a debate. Mobile C-arms might offer sufficient quality for standard EVAR and are more compact, cheaper. But for complex, prolonged procedures, the advantages of a hybrid suite Better imaging, better heat capacity, precise movements, advanced features like fusion CBCT, and crucially, better integrated operator shielding often outweigh the potential for a slightly higher patient dose, which can itself be managed with technique.
So the recommendation leans towards fixed systems.
Yes. Recommendation 23 is Class 2A, Level C. An endovascular operating room with a fixed imaging system should be considered over a mobile C-arm, particularly for optimizing imaging quality and reducing operator exposure through integrated shielding.
What about controlling the imaging, operator-controlled imaging, OCI?
This refers to the ability for the primary operator to control fluoro and DSA directly from the tableside console, common in hybrid suites, rather than asking a radiographer or technologist to do it.
Is that better for safety?
The guidelines suggest it should be considered. Recommendation 24 is Class 2A, Level C. The rationale is that it avoids unnecessary exposures that can happen due to miscommunication, unclear instructions, language barriers, ambiguous words leading to exposure at the wrong time or for too long.
Any evidence it reduces dose?
One study referenced found a 30% lower median DAP when the operator controlled the imaging compared to when a technologist did. However, the guidelines note more data is needed. If you don't have OCI, clear, concise communication protocols are absolutely vital.
Okay, let's talk positioning around the patient. This seems fundamental.
It absolutely is. Basic physics principles apply directly here. First, imaging chain geometry. Remember the setup. X-ray source, usually under the table. Bication-Billy detector above the table.
Got it.
Table height matters. Raising the table increases the source to patient distance, which slightly reduces patient skin dose due to the inverse square law from the source. However, raising the table also tends to increase the scatter radiation, reaching the operator's upper body, head, and eyes.
So lower table is better for operator head dose?
Generally, yes, but potentially slightly higher patient skin dose. It's a balance. What's clearer is the patient-to-detector distance. Recommending 25 is Class 1, Level B physics principle. The patient should be positioned as close as possible to the detector, image intensifier, or flat panel.
Why close to the detector?
This improves image quality, less geometric unsharpness, and reduces the radiation needed to get a good image, thus lowering patient dose and subsequent scatter. Also, operators should position their own chest and head as far from the patient as practical, because the patient's body is the main source of scatter radiation.
Okay, patient close to detector, operator far from patient. What about gantry angulation?
This is a huge factor for both patient and operator dose. Using steep C-arm angulations, strong lateral views, or significant cranial or caudal tilts drastically increases radiation dose.
Why do steep angles increase dose so much?
Several reasons. First, the X-ray beam has to penetrate a thicker cross-section of the patient's body, so the system's automatic exposure control ramps up the radiation output significantly to maintain image brightness. DAP can easily double, going from AP to oblique.
More tissue, more power needed.
Second, steep angulations change the geometry and direct more scatter radiation towards the operator's upper body. This increase is exponential, especially beyond 30 degrees lateral or 15 degrees cranial angulation. Full lateral is often the worst for operator head-eye dose.
Wow, exponential increase in scatter to the operator.
Yes. Third, steep angles, particularly caudal angulation with the source under the table, can bring the X-ray source much closer to the patient's skin, significantly increasing the entrance skin dose and the risk of deterministic skin injury. One study noted 83% of skin injuries occurred with steep angulations.
So, multiple reasons why steep angles are bad news for dose.
Definitely. Maintain maximum distance from the source when steep angles are necessary. A phantom model cited showed operator exposure going from 5 millisVAR in AP view to 11 millisVAR at 45 degrees and a whopping 69 millisVAR at 90 degrees lateral.
14 times higher at 90 degrees.
It shows the dramatic impact. Complex repairs often require these angles, leading to higher head-level scatter. So the recommendation is strong. Recommendation 26 is Class 3, Level B physics principle. Prolonged use of steep gantry angulation is not recommended. Use AP or mild obliques whenever possible.
Okay, minimize steep angles. What about just distance? The inverse square law.
The simplest, cheapest, and arguably one of the most effective dose reduction techniques for staff. Remember, scatter radiation from the patient is the main source of your occupational exposure. The inverse square law intensity, 1 distance squared, applies directly to this scatter.
Double the distance.
Quarters the exposure rate.
Yeah.
Triple the distance, the exposure rate drops to 1/9. It falls off incredibly quickly.
So the practical application.
Step away. Whenever you don't need to be right next to the patient at the table, especially during high-dose acquisitions like DSA or CBCT, take a step or two back. Even one step makes a significant difference. If possible and practical, exit the room entirely during long DSA runs if your presence isn't required.
Simple but powerful. Where around the table is the worst spot.
Positioning around the table matters. Scatter intensity is highest on the side where the X-ray beam enters the patient. With the source typically under the table, this means scatter is highest directed downwards and outwards from underneath the table.
So closer to the source side is worse.
Yes. Also, certain projections, like a left anterior oblique, LAO, with the operator standing on the patient's right, will position the operator closer to the entrance beam path and result in higher exposure. Primary operators generally receive higher doses than assistants, sometimes twice as high in complex cases.
And the pattern isn't perfectly circular.
No, the table structure itself affects the scatter pattern. Studies show lateral projections can give 7 times higher exposure than 45-degree obliques, with the maximum scatter being on the side of the X-ray tube emitter.
So be aware of where the tube is, especially during DSA.
Yes, move personnel away from the patient, particularly if they're on the emitter side during DSA runs. And crucially, inform your anesthetic colleagues. They're often positioned at the head of the table, potentially very close to the source doing certain angulations, and can receive significant doses if unaware or unprotected.
Good point about the whole team. One last technique. Remote contrast injectors.
Yes, highly recommended overhand injections, especially during DSA. Why? Because if you're hand injecting during DSA, your hands and upper body are right next to the patient, exposed to high scatter levels during the highest dose acquisition mode.
How much does hand injection contribute?
One study referenced estimated that hand injection accounts for about 75% of the total operator exposure during DSA runs.
3/4 of the dose just from injecting?
Exactly. Using a remote injector allows you to step back, often behind shielding, while the contrast is injected and the DSA is acquired, dramatically reducing your exposure during that critical phase. Okay, that was a lot on techniques. Let's quickly summarize the key practical takeaways for dose reduction.
Good idea. So ALRA is the goal. Think about pedal time, short taps, last image hold.
And be incredibly mindful of DSA, lowest frame rate necessary, limit runs, consider fluoro loops instead. DSA is a huge dose driver.
Collimation is your friend. Use it aggressively to reduce scatter. Think about removing the grid for low scatter cases.
Leverage technology. New hardware software, pre-op planning is crucial, image fusion for complex cases, and digital zoom instead of conventional magnification.
Right. Avoid that dose penalty from conventional mag. Use the dose reports to track your performance. Maintain your equipment.
Choose fixed system hybrid suites over mobile C-arms, if possible, for better operator protection. Consider operator-controlled imaging.
And positioning is key. Patient close to detector. Avoid prolonged, steep C-arm angles. That's a Class 3 recommendation, not recommended.
And the big one. Use the inverse square law step back, especially during DSA. Know the high scatter zones around the table. Use remote injectors.
Applying these consistently is paramount for minimizing dose to everyone. #radiation protection equipment.
Now let's talk about your protective gear, radiation protection equipment. These are complementary to all the techniques we just discussed. You need both.
Right. Technique first, then shielding.
Exactly. Shields are either personal protective devices that you wear, or they are barriers positioned between you and the patient, who is the primary source of scatter. The medical physicist plays a role in advising on appropriate shielding. And note, modern shields often use non-lead materials, like composites with bismuth, tungsten, antimony.
Okay, let's start with personal protection devices. The wearable apron.
The absolute foundation. Lead aprons or lead equivalent aprons are incredibly effective, lowering radiation exposure to the covered parts of the trunk by over 90%. Standard practice everywhere.
And the recommendation.
Recommendation 29 is Class 1, Level B, Physics Principle. All personnel present in the room during radiation use must always wear a well-fitting protective apron.
What about thickness?
At least 0.35 millimeters of lead thickness equivalence is required for the front. For operators with high workloads, like Category A workers, a wraparound-style apron is ideal. This typically offers 0.25 millimeters lead equivalence on both the front and back panels, which then overlap on the front, providing 0.5 millimeter equivalence where it matters most.
Fit matters too, right? A poorly fitting apron leaves gaps.
Absolutely. It needs to fit well.
Yeah.
And you need to check its integrity periodically. Visually inspect for tears or damage, and occasionally check it under fluoroscopy for hidden cracks in the protective material. Recommendation 31, Class 2B, Level C, suggests aprons should be assessed annually.
Are there different types? Lead versus non-lead?
Yes, traditional lead aprons and newer, lighter, non-lead composite aprons. They have slightly different attenuation properties at different X-ray energies, and weight is often a factor in choice, especially for reducing musculoskeletal strain.
What about protecting specific areas? Breast protection.
Recommendation 30 is Class 2A, Level C. Consider using axillary supplements or protective sleeves, particularly for female operators, to provide better lateral breast protection, as standard aprons might not cover this area fully.
Okay. Next item, thyroid collars.
Also essential. The thyroid gland is quite radiosensitive, and dose to the neck can exceed occupational limits if it's left unprotected, especially with scatter coming up from the patient.
So always wear one.
Always. Recommendation 32 is Class 1, Level C. All personnel present, M. Haze D, always wear thyroid collars. Make sure it fits snugly.
What about lower down? Leg shields.
Yes, scatter radiation definitely reaches the lower extremities, areas often not fully covered by standard aprons. Remember that study showing DNA damage in lymphocytes was mitigated by leg shielding.
Right.
So, especially in high-dose environments, or if table-mounted shields, which we'll get to, aren't providing full coverage, consider additional protection like lead leggings or mobile tibial shields. Leg doses up to 2.6 millisieverts per procedure have been reported without specific shielding.
Okay, now for the eyes. Eye protection, leg glasses. This seems critical given the cataract discussion.
Absolutely. See a ritual. We know operators have a higher prevalence of lens changes. We know the threshold for radiation-induced cataracts is now thought to be much lower than previously believed, possibly less than 2 GTi, maybe even no threshold, with risk reported below 0.5 G.
An eye dose can be significant.
Yes, without protection, annual eye lens doses for busy interventionists could potentially exceed the occupational limit of 20 millisieverts per year. This makes eye protection non-negotiable.
So the recommendation is strong.
Extremely strong. Recommendation 34 is Class 1, Level B. Endovascular operators must always wear appropriately fitted lead glasses or visors offering at least 0.75 millimeters of lead equivalents. Fit is important to prevent scatter coming in around the edges. Side shields help too.
Is this as critical for other staff in the room?
The risk of RIC is considerably lower for non-operators like nurses or techs standing further back, simply due to the inverse square law reducing their scatter dose significantly. But for the primary operators close to the table, it's mandatory.
Okay, mandatory lead glasses for operators. What about radiation protective gloves?
This is an area where the recommendation is actually against routine use. Recommendation 36 is Class 3, Level C. Routine use of radiation protective gloves is not recommended.
Why not? Don't they protect your hands?
They offer some attenuation, yes, and might be considered if your hands absolutely must be very close to or within the primary beam for a brief moment, like during a complex vascular puncture assist. BU key?
There's a catch.
A big one. If you place a gloved hand directly in the primary beam, the attenuation from the glove material causes the automatic exposure control system to significantly increase the radiation output to compensate.
So it boosts the dose?
Yes, it increases the dose to the patient and paradoxically can even increase the dose to the operator's body due to increased scatter and may not fully negate the increased primary beam dose to the hand itself.
So wearing gloves might make things worse overall?
In many situations, yes. The best protection for your hands is simply keeping them out of the primary X-ray beam altogether. Use instrument holders. Be mindful of positioning.
So how do you protect hands during puncture then?
Technique. Recommendation 35 is Class 1, Level B, Physics Principle. Routine use of ultrasound-guided artery puncture technique is recommended over fluoroscopy-assisted puncture. Ultrasound guidance eliminates the need for radiation during access, protecting both patient and operator hands.
Use ultrasound first.
Definitely. If you must use fluoro for puncture, use a long needle holder or syringe extension to keep your fingers further from the beam. If protective gloves are deemed necessary for a specific brief task, single-use non-lead sterile gloves are generally recommended over reusable leaded ones.
Okay, avoid routine gloves. Use ultrasound for access. Keep hands out of the beam. What about head shields?
There have been some concerns raised in the literature about the potential risk of brain tumors in interventionists, citing some case reports. However, a true increased risk hasn't been definitively established.
And head shields exist.
Yes, lead caps or shielded surgical caps. Older versions were quite heavy, over a kilogram, which could pose a musculoskeletal hazard itself. More research is needed on the effectiveness, comfort, and practicality of modern, lighter head protection options. It's not a routine recommendation currently like aprons or glasses.
Got it. Let's move to other radiation shielding equipment things not worn directly.
Right, equipment in the room. One option is suspended personal radiation protection systems.
What are those? Like the zero gravity system?
Exactly, that's a well-known example.
Hmm.
These systems involve a ceiling-mounted boom suspending a large shield that covers the operator's entire body. It essentially replaces the lead apron, thyroid shield, maybe even shin guards.
And the benefit.
They offer superior protection to the whole body compared to standard personal protective equipment. Studies cited show significantly lower body doses, dramatic reductions in annual effective days, and up to 94% reduction in head-level dose compared to just apron glasses.
So much better protection.
Yes, they can be justified in very high-dose environments or for operators with specific health concerns like back problems exacerbated by heavy aprons. You likely still need lead glasses, though, and they might interfere with the use of ceiling-mounted shields we'll discuss next.
Okay, what about those fixed shields, shielding above and below the table?
These are critical components, especially in fixed hybrid rooms. Above the table, you have ceiling-mounted shields.
The clear lead acrylic screens hanging down.
Yes. They are positioned between the patient and the operator's upper body and head to intercept scatter radiation traveling upwards. Their use is mandatory. Recommendation 38 is Class 1, Level B, Physics Principle. Ceiling-mounted lead acrylic shields must be used. Position them as close to the patient as possible without obstructing the view or procedure.
And below the table.
Table-mounted lead skirts or drapes. These are flexible curtains, typically 0.5 millimeters lead equivalents, that hang from the sides of the patient table down towards the floor.
What do they block?
They block the scatter radiation coming from under the table, protecting the operator's legs and gonads. They are considered highly effective as first-line protection for the lower body.
Also mandatory.
Yes. Recommendation 40 is Class 1, Level B, Physics Principle. All operators must use table-mounted lead skirts as first-line protection at all times. Ensure they're deployed correctly and aren't pushed out of the way.
So ceiling shield for the top, table skirt for the bottom essential. What about drapes on the patient? Radiation protective patient drapes.
These are sterile drapes, often containing non-lead attenuating materials like bismuth or tungsten antimony that are placed on top of the patient near the area being imaged.
How do they help the operator?
They work by attenuating the scatter radiation right at the source of the patient's body before it can travel toward the staff.
Do they work well?
Phantom studies show very significant scatter reduction at operator locations. Cited examples include 12 times reduction at eye level, 25 times at the thyroid, 29 times in the hands.
Wow, huge reductions in phantoms. What about in real patients?
Clinical studies, mostly from cardiology initially, show operator dose reductions typically in the range of 20–80%. Endovascular studies are also promising, showing reductions like 49–55% for the operator and 48% for the nurse's chest dose during EVAR, and 65% reduction in lower limb procedures.
So, good evidence they help reduce operator dose.
Yes. Diligent use of ceiling shields, table skirts, and these patient drapes is recommended. Used in combination, they can create a very effective attenuation barrier, potentially reducing scatter close to background levels in some configurations.
Is there a downside or caution?
Yes, a crucial one. You must avoid placing these protective drapes directly in the primary X-ray beam. If the drape is in the beam, its attenuation will cause the AEC system to increase the output, just like with the gloves.
Increasing patient dose and potentially scatter, too.
Exactly. So position them carefully adjacent to the beam entry site on the patient's side facing the operator to intercept scatter without obstructing the primary beam. Their use might also differ slightly between cardiology, where operators are often more static, and endovascular, where operators may move around more. All right, let's quickly summarize the protection equipment essentials.
Okay. Foundation is the well-fitting apron, 0.35 millimeters plus lead equivalent, and the mandatory thyroid collar.
Then, absolutely critical, mandatory lead glasses, 0.75 millimeter plus lead equivalent for operators, due to the RIC risk at low doses.
Consider leg shields for lower body scatter. Routine protective gloves are not recommended. Keep hands out of the beam. Use ultrasound for access.
Right. In the room, mandatory ceiling-mounted shields above and table-mounted skirts below.
Suspended systems offer superior full-body protection for high-dose settings. And radiation-protective patient drapes are very effective at reducing scatter when used correctly placed on the patient but out of the primary beam.
Using these layers, personal gear, fixed shields, patient drapes in combination, provides the best protection. #tag education and training in radiation protection.
Okay, we have the techniques, we have the gear, but none of it works if people don't know how or why to use them. Let's talk education and training.
This is a critical piece and, frankly, an area where the guidelines highlight significant shortcomings. There's an alarming reported knowledge gap regarding basic radiation protection principles among many medical professionals involved in X-ray guided procedures.
Especially trainees.
Yes, trainees often score poorly on knowledge assessments. Surveys mentioned show many vascular trainees feel they have insufficient training, are unaware of institutional policies like for pregnant workers, or don't even know the acceptable occupational dose limits.
That's concerning.
It is. One U.S. survey even reported some trainees exceeding dose limits. It underscores that radiation safety education and training must be a priority for all personnel in the endovascular operating room. Doctors, nurses, techs, everyone at every single level of training and experience.
So who should provide this training?
The guidelines suggest the primary trainer should be experts. Ideally, a combination of a medical physics expert who understands the technical physics and regulations and a radiation protection certified clinician who actually works with radiation daily and can make it clinically relevant.
Makes sense. And the training itself.
Needs to be relevant to their role, manageable in terms of time commitment, and very clinically oriented, not just dry physics lectures. It should include initial basic education for everyone entering the environment, and then more in-depth, specific training for specialists who are regularly using the equipment.
Are there standards for this?
Yes. Curricular recommendations exist from international organizations like the ICRP, European Commission, and WHO. A European survey found that while mandatory radiation protection courses exist in about two-thirds of countries, the specifics vary widely when the training happens, whether hands-on components are required, how often recertification is needed.
So variability, but the need is clear.
Absolutely. Recommendation 43 is Class 1 level law. All personnel who may be exposed to radiation must have the appropriate level of radiation protection training for their role. And Recommendation 44, Class 1 Level C, recommends including radiation protection content in National Vascular Board certification exams.
What kind of training formats work best? Theoretical courses.
Traditional classroom lectures are common, but e-learning modules are increasing, offering flexibility and accessibility. The curriculum needs to cover the essentials: radiation physics, radiobiology, risks, the safety principles, justification, optimization ALERA, limitation, relevant legislation, and proper use of equipment and techniques.
What about practical training?
This is seen as highly beneficial, especially when done in a simulated environment where you can practice techniques without actual radiation exposure. Availability varies, but some countries, like Switzerland cited in the text, mandate hands-on training days.
Simulation sounds useful.
Very. There are even web-based simulators that allow operators to virtually adjust C-arm settings, like frame rate, collimation, angulation, and immediately see the impact on simulated dose readings, KAP, PSD, operator dose. It's a great way to learn the cause and effect relationship.
And getting feedback.
Crucial. Regular evaluation and formative feedback on radiation safety performance, whether in simulation or during real cases, perhaps reviewed afterwards, is needed. Using validated rating scales can help make this objective.
Does simulation training actually translate to better practice?
There's evidence it does. The Prospect trial, mentioned in the source, found that simulator training for endovascular skills not only enhanced operative performance, but also showed a trend towards trainees using less contrast medium and less radiation during actual procedures.
So learning skills in a radiation-free sim seems beneficial for dose reduction later.
Yes, the guidelines acknowledge the benefit of learning and practicing endovascular skills in a safe, radiation-free simulated environment for reducing real-life goes, especially for trainees or visiting personnel getting familiar with procedures.
When should this education happen? Timing.
Ideally, access to facilities using radiation should be restricted until at least core knowledge about safety has been obtained. For future operators, the education needs to be integrated throughout residency, starting early to establish correct practices from day one.
Not just a one-off course.
No. While single courses are useful, the evidence suggests that regular, detailed, personalized feedback has a greater impact. This means comparing an individual's radiation usage, for example, their typical KAP for a specific procedure, to their peers and external benchmarks like DRLs. That really drives behavioral change.
And it needs to be ongoing.
Yes. Regulatory and health authorities usually enforce initial training, certification, and periodic updates or recertification. Recommendation 46 is Class 1 level law. National policies regarding continuous training and certification with formal assessment must be followed.
How often?
The guidelines show a figure suggesting a timeline. Initial theory and hands-on before exposure, then periodic reevaluation and maintenance training, perhaps every 36 months or even more frequently depending on national rules or local policy. Ideally, evidence of certification should be tracked centrally. Scientific societies also have a role in promoting ongoing training through lectures and refresher courses.
Okay, let's try to bring all these threads together. What does this comprehensive look at the ESVS radiation safety guidelines mean for you, the specialist clinician, in practice?
Well, we've drilled deep into measuring and monitoring dose understanding HP 0.07, HP 10, HP 3 from your dosimeter, and the value of real-time feedback from active personal dosimeters versus the historical record from TLDs.
We spend a lot of time on the huge array of dose reduction techniques. Optimizing C-arm settings, remembering the massive dose impact of DSA frame rate, and minimizing pedal time.
Right. Leveraging modern hardware and software, the critical importance of preoperative planning and considering image fusion. Understanding the physics collimation, keeping the patient close to the detector, the huge benefit of digital zoom over conventional magnification.
And applying the inverse square law, stepping away. Avoiding prolonged, steep angulations, knowing the scatter zones, using remote injectors, these are all active choices you make in every case.
Then there's the essential equipment, your personal gear, the apron, thyroid collar, and those mandatory lead glasses. Recommendation 34, Class 1. Level B operators must wear them, especially with the evolving cataract data.
Plus, the fixed shield, ceiling, and table skirts are mandatory, and considering patient drapes, used correctly outside the primary beam. Remember, layers of protection work best.
And underpinning everything is a critical need for robust, ongoing education and training. Addressing those knowledge gaps, using simulation, getting personalized feedback, and meeting certification requirements. It's about building and maintaining a strong safety culture.
So a question for you, our listener, to consider. Based on the dose parameters we discussed, air kerma area product, peak skin dose, and effective dose, which parameter would you prioritize for auditing your individual procedural radiation exposure related specifically to the risk of deterministic effects like skin injury or potentially cataracts? Think about the thresholds we mentioned and which dose quantity directly relates to hitting those thresholds in specific tissues.
That would likely be peak skin dose for skin reactions and perhaps HP3 or a dedicated eye dosimeter reading for cataract risk, wouldn't it? Because those relate directly to dose thresholds in the relevant tissues. AK and KP are great overall procedure metrics and effective doses for stochastic risk, but PSD and iDose are key for deterministic effects. #tag future technologies for gaps in evidence.
Finally, let's look ahead briefly. Future technologies and gaps in evidence.
An important point the guidelines make is that many recommendations are actually based on level C evidence, expert opinion, case series, physics principles, rather than high-level randomized trials. So there's definitely a need for future studies to strengthen the evidence base for many of these practices.
But we should embrace new tech.
Yes, technologies that promise to reduce reliance on X-ray guidance should be embraced and evaluated carefully, perhaps using frameworks like the ideal recommendations for surgical innovation.
What specific technologies look promising?
One area is robotic tracking. Robotic navigation systems for catheters and guide wires offer enhanced steerability and potentially allow remote control from a shielded console, which could be beneficial in complex EVAR, like fever-BVAR.
And the radiation aspect.
Models show negligible operator radiation exposure when using the remote console, and early clinical evaluations show safe target vessel cannulation. But prospective studies are still needed to definitively prove clinical advantages and cost-effectiveness over conventional techniques.
What about artificial intelligence, AI?
AI holds significant potential for dose reduction in fluoroscopy-guided interventions. Examples include AI algorithms that automatically adjust image processing to improve visualization of devices using less exposure, maybe using distinctive colors or enhancing resolution selectively, like the fiber optic real-shape technology mentioned conceptually.
Could AI help with collimation or warnings?
Potentially, yes. You could have automated recognition of the region of interest to guide collimation or deliver radiation more selectively. Imagine AI that provides automated intraoperative dose reduction suggestions or even warning systems like an alert if the operator forgets to step back during a DSA run.
Has this been used elsewhere?
An integrated AI system in endoscopy was cited as showing reduced patient DAP and scatter dose. The guideline suggests similar AI systems could be applied to endovascular procedures.
What about gaps in practice or evidence?
One major gap is global harmonization. While EU legislation sets overall dose limits and requirements, the specific details on things like PPE standards, dosimetry protocols, and monitoring frequency can vary significantly between countries. Lack of international standardization makes comparisons difficult and might hinder optimization. There's a need to review and compare national regulations.
And education gaps remain.
Yes, definitely. There's a need for structured train-the-trainer programs, combining medical physics and clinical expertise. And importantly, we need more structured studies to objectively assess how effective radiation safety courses actually are in improving trainee knowledge, skills, and long-term behavior in clinical practice. #tag outro.
Okay, let's bring this deep dive to a close. We've covered a significant amount of ground from the ESVS 2023 guidelines on radiation safety in endovascular procedures.
We certainly have. From the fundamental measurements like KAP and AK to understanding stochastic versus deterministic risks, especially that evolving picture for cataracts.
Through all the practical dose reduction techniques, the essential protective equipment layers, and landing on the critical need for ongoing, effective education and training for the entire team.
It's clear that while endovascular procedures are life-saving and getting more complex, radiation safety is an absolute cornerstone that requires continuous attention and effort from everyone in the room.
Applying that LRA principle through conscious technique, really leveraging the technology and shielding available, diligently monitoring exposure, and committing to continuous learning.
These aren't just nice-to-haves or best practices. The guidelines frame them as fundamental responsibilities for anyone performing these procedures.
So as procedures continue to evolve and become even more complex and new technologies emerge, the final thought we want to leave you with is this. How will you ensure your practice not only stays cutting edge clinically, but also remains maximally radiation safe for your patients, your team, and yourself?
That ongoing vigilance and commitment to optimization is key.
This concludes our deep dive into the ESVS 2023 Clinical Practice Guidelines on Radiation Safety.